So it is with great pride and pleasure that I am here to announce our speaker. Dr. Kenneth Warrington here is a consultant and chair, Division of Rheumatology. Take my glasses off here. That doesn't work for me. The Department of Internal Medicine and director of the Vasculitis subspecialty group at the Mayo Clinic here in Rochester, Minnesota. Dr. Warrington's clinical focus includes expertise in evaluation and management of all forms of vasculitis. And he specializes in complex coordination of care with other specialists, focusing on the care of patients with vasculitis and promoting each patient's understanding of disease and empowering patients to become partners in managing their health. He also holds the academic rank of Professor of Medicine, Mayo Clinic College of Medicine and Science. So please join me in welcoming Dr. Warrington, please.
Well, good afternoon, everyone. It's a pleasure to be here with you all, and thank you for coming. I'm excited to talk to you about vasculitis. As you know, this is a session that has information that's more relevant to folks that are newly diagnosed, but even those who perhaps have had disease for a while may find some of this helpful and of knowledge to you. These are my disclosures. These companies have provided support for clinical trials conducted at Mayo. So I thought I'd base this talk around some common questions that I've heard from patients of mine that come to the clinic and have a new diagnosis of vasculitis, or vasculitis is strongly suspected. And I thought of some common questions of what patients ask. And one of the first things is, what is vasculitis and why am I seeing a rheumatologist? Some patients say, I don't have arthritis. They told me, you're an arthritis expert, and why am I seeing you? So as you may know, inflammation of blood vessels is something that's common to all forms of vasculitis. But when we talk about inflammation, sometimes that can be a little vague. And what does inflammation really mean? In some situations, like here, if somebody has an injury to their finger, whether it's a small cut, needle stick, a bug bite, then I think we can easily see and understand what inflammation is, because that area is going to be red, it's going to be hot, painful, swollen, etc. And we can see and feel that inflammation. But in vasculitis, it's really impossible to see that inflammation as clearly as we're seeing it here on this finger. So what really is inflammation? So inflammation is really a normal response of the body in response to either injury or, say, infection. So when there is inflammation, like in this example here, say there's a small cut in the skin, there's going to be bacteria that get into the skin with that cut, and then our body has to respond to that. So the way the body responds, I guess you're having some hiccups here with the slides, but hopefully we'll get that sorted out. But what happens is the body is going to take those white blood cells. So normally white blood cells are circulating in the blood. White blood cells are these little purple dots here. They're normally circulating in the blood. They're all over the body. And they are the cells that are going to be detecting, is something wrong? Is there an invader? Is there an infection? Is there inflammation? So these white blood cells will go to areas that need healing, and they will generate this inflammation, meaning they will generate a response that causes some swelling, maybe some redness, some warmth. There may be pain at the area, but really that's the first phase of healing, where then those white blood cells are going to help promote healing of that cut. They're going to kill those bacteria. They're going to perhaps cause some scar tissue and lead to healing of that injury. But in vasculitis, of course, the inflammation is not appropriate. So here in the picture I'm showing you, vasculitis is appropriate. Those white blood cells are there with a purpose to fight infection, to promote healing when there is injury. But in vasculitis, the inflammation is not appropriate. So first of all, hopefully you can see this soon, but what's a normal blood vessel? So a normal blood vessel looks like this, right? It's like a tube or a hose. And if we were to cut the artery, and you're able to see it, then we would see that in what we call cross-section in medicine. So if we take a slice through the middle and turn it on its side, then we're able to see that it really is again, a tube, and the tube has a wall, and on the inside is what we call the lumen, which is really where the blood is flowing through. So that's a normal blood vessel. In the context of vasculitis, the blood vessel looks different. So what has happened? So now these white blood cells, which normally protect us from infection, have now decided to go in and invade the wall of blood vessels and cause inflammation in that location, which is not appropriate. And really, we don't understand why this happens. Why do these white blood cells, as you saw in the earlier talk, it's really the person's immune system turning against oneself, and these white blood cells are now invading the wall of a blood vessel, and they're setting up shop and forming inflammation. The blood vessel does not like that. So the first thing with inflammation, we said, one of the things is swelling, right? So if you have swelling in the wall of a tube, that wall is going to become thick. And you may have heard your physicians talking about thickening of the blood vessels, maybe on a scan or so, and so. But when that wall becomes thickened, here now the inside, the lumen, where blood is supposed to be flowing through, is compromised. So now the inside of the blood vessel is smaller than it should be. Now this depends on the size of the blood vessel, because if small blood vessels are affected and there are white blood cells invading the wall of a very tiny blood vessel, like a capillary, as we see in the skin, for example, or in the lungs or the kidneys, those capillaries may be damaged to the point that the wall of the blood vessel tears or ruptures, and then blood is leaking out. So whether it's because the blood vessel is too narrow, or whether it's because the blood vessel now has ruptured or is leaking, the bottom line is that the blood flow on the inside of the artery is not getting to where it should be. And if we're not delivering blood supply to the organs, if we're not delivering oxygen, nutrients, etc., to part of the body, then there's going to be a compromise to that organ and damage to that organ. So again, in vasculitis, we have inflammation of the blood vessels. Like I showed you, it's this white blood cells that are invading, penetrating the wall of the blood vessel. That leads to narrowing of the blood vessel, may eventually lead to a complete blockage. In some blood vessels, like in the capillaries, when we're talking about the lungs or the kidneys, there may be leaking of blood and or lack of blood flow. So this will result in lack of blood flow and then damage to internal organs. So if we're talking about a blood vessel supplying the brain, there may be stroke because of nerve damage. If we're talking to blood vessels in the lungs, there may be hemorrhage in the lungs and bleeding. If we're discussing blood vessels to the kidneys, there may be kidney damage and kidney failure. So vasculitis is not one disease, as you know. That's why many of you are here with all sorts of different diagnoses. But the one thing you have in common, and the one thing vasculitis has in common, is that there's blood vessel inflammation in all these diseases, and they are all considered autoimmune diseases, meaning it's the immune system that's turned on your own body. We treat these diseases with medicines that suppress the immune system. Of course, you've all heard of prednisone and other glucocorticoids or steroids, and other medicines that will be used to dampen the immune system. So now we want to dampen the immune system. We want to kind of slow down those white blood cells so they're not invading, they're not damaging the blood vessels as we saw earlier. Well, and that's the reason then you are seeing a rheumatologist, because the rheumatologist is generally best knowledgeable and equipped to understand and treat autoimmune diseases, because we generally treat autoimmune diseases affecting the joints, like forms of arthritis, like rheumatoid arthritis, other autoimmune diseases like lupus, and vasculitis is treated with very similar medicines, steroids and other immune suppressants. And that's how the rheumatologist will become then the coach, the leader of the team that takes care of patients with vasculitis. And as we'll talk more, you'll see that really is a team of providers that take care of patients with vasculitis. So what about some other questions that I've heard in clinic? Why the confusing terminology, right? Your doctor says, I have vasculitis. But then you go to your rheumatologist, they say you have Wegener's disease or Wegener's granulomatosis. But then the other rheumatologist who's covering on the weekend said, no, you have GPA or granulomatosis with polyangiitis. The nephrologist called it ANCA-associated vasculitis. And of course, that's really our responsibility now to just cause all this confusion with our terminology. But at the end of the day, these four physicians all mean the same thing. Because one could say vasculitis, which is just a very broad term, and there are many types of vasculitis. Wegener's disease is one type. We no longer call it Wegener's disease because Dr. Wegener was involved in some World War II experimentations, and the name was changed to granulomatosis with polyangiitis, or GPA. A lot of patients with GPA have a blood test called ANCA, which we'll talk more about. So calling it ANCA-related vasculitis or ANCA-associated vasculitis is also correct. But I understand how this terminology sometimes can create discussion or perhaps confusion. So when we think about vasculitis, so kind of going back to the big category, and we talk about vasculitis, the first thing we do as physicians is we try to understand, are the blood vessels that are affected by this inflammation, by this damage from the immune system, is it the large blood vessels in the body? And the largest blood vessel is the aorta. The aorta is the largest blood vessel that comes out of the heart, and then it divides into many branches that supply the rest of the body. There are then arteries, which again are forming sort of smaller branches, like the branches of a tree, that are now inside organs. Here's a picture of a kidney with smaller arteries going into the organ, in this case the kidney. We call those medium-sized arteries. Eventually, if we were to take a small biopsy of the kidney here and look at it in the microscope, we'll see that the kidney has a lot of these little bunches of capillaries, or very, very tiny blood vessels. So blood vessels come in all sorts of shapes and sizes, but in terms of the sizes, we go from the largest, being the aorta, to the very smallest, the capillaries. And then we try to think which of these blood vessels is affected in the patient that we're evaluating. And then we can try to identify a specific disease. So as you may know, some of you may be diagnosed with giant cell arteritis or with Takayasu arteritis. Those are two diseases that affect the largest blood vessels in the body. Mainly the aorta, again that's the first blood vessel coming out of the heart, or its branches often going to the head, to the arms. Similarly with Takayasu arteritis. When blood vessels that are a little bit smaller but kind of in the medium range size are affected, that condition, polyarteritis nodosa, often affects the arteries in the kidney, perhaps in the gut and the abdomen, and nerves and skin. But then the very tiniest blood vessels are generally affected in a group of conditions like GPA, MPA, and EGPA, or Church-Strauss. And those conditions, GPA, MPA, and EGPA, a lot of people with those diseases have a blood test called ANCA, which we'll talk a little bit more about. And so then we can group those three diseases together and call them ANCA vasculitis, which is why I said somebody who's been told, a patient with GPA may be told they have vasculitis, which is correct. They may be told they have Wegener's disease, because that's kind of an older name for the condition, or it could be GPA, but you could also call it ANCA-associated vasculitis. And in fact, a lot of physicians and experts in the field are now going towards calling GPA, MPA, and EGPA with the broader term of ANCA-associated vasculitis. There are some other less common conditions, which I know there will be specific breakout sessions on. For example, IgA vasculitis or cryoglobulinemic vasculitis, and those are also forms of small vessel vasculitis, in some ways, affecting similar blood vessels in size to the blood vessels that are affected by ANCA-associated vasculitis. There's a condition that some of you may have. I know at the conference, at the symposium, there are individuals with Behçet's disease, and this has its own category. So Behçet's disease causes mouth sores and genital sores oftentimes, but it also causes blood vessel inflammation, and it's put in its own category called variable vessel vasculitis because it can affect small, medium, or large arteries, all kind of in the same individual or in different individuals. Then there's another category of vasculitis that you may have heard of called single organ vasculitis. And single organ vasculitis means that the vasculitis is only in one part of the body. For example, this individual here with a rash has vasculitis. I'm sure you may have experienced or have seen pictures of a vasculitic rash, which is what we call purpura. And this is again because the small blood vessels, the capillaries in the skin are affected. Those blood vessels are damaged, they leak, and you have leakage of blood underneath the skin. So this individual has vasculitis which is only in the skin. And in that situation, we call that a single organ vasculitis. It's only in one organ. Now, single organ vasculitis can be relatively easily treatable as when it's in the skin. But then, of course, there are individuals who have it in the skin and who have it in other organs. Or there are individuals where the organ that's affected by vasculitis is in an organ such as the brain. And of course, that can have significant consequences such as stroke symptoms and so forth. So bottom line is, vasculitis, as you know, usually affects multiple organs in the body at the same time, but there are instances where vasculitis can be only in one organ and sometimes becomes a little bit more difficult to diagnose. So some other questions. Who gets vasculitis? And why did I get vasculitis? And I wish I had better answers to these questions, because the answers are somewhat vague, but we do know that vasculitis can affect anyone and everyone. Whether it's children, adults of any age, both men and women, any race or ethnicity, it's worldwide. But it does depend then on the specific type of vasculitis. So sometimes the age of the individual, the age of the patient, is helpful for us in terms of trying to narrow down which specific form of vasculitis are we dealing with. So if we see somebody where, for example, the aorta is affected, a large artery, then we have narrowed it down to saying, this might be giant cell arteritis, this might be Takayasu, but then we know that Takayasu affects young women preferentially, whereas, for example, giant cell arteritis tends to be a disease of folks who are more in their 60s and 70s. So there are some clues that can help us identify which type of vasculitis. IgA vasculitis, for example, tends to occur more in children. So there are some differences. There are some worldwide differences. For example, giant cell arteritis is more common in individuals of Northern European descent and maybe less common in other parts of the world. But again, vasculitis can affect anyone and at any age. The question of, why me and what causes vasculitis, there's still a lot of unanswered questions there that we all want answers for, and again, we're all, I think, working on some of those answers. But the bottom line is vasculitis is likely a combination of a number of different things that are coming together in a single individual. These are rare diseases. But there are some things that we know about. There may be some genetic contribution to the disease. It's not a straightforward genetic inheritance like some diseases that are passed down from one individual generation to another. But it's usually a combination of genes, and what we tell patients is that it's often not one gene, but a combination of genes. Most of the studies have shown that they're often genes related to immune function and related to the immune system. And these genes have to come together in kind of the right combination or the right pattern to lead that individual to be susceptible to vasculitis. And that's probably not enough, because there is likely something in the environment, and we and others have always looked at the potential for infections that may be triggers for vasculitis. So something that turns the immune system on, but for reasons we don't understand, the immune system then is not able to turn itself off. So most individuals who have an infection, the immune system becomes activated to fight the infection, and then once it's done its job, it turns itself off. In people with vasculitis, the immune system is not very good at turning itself off. It remains persistently active, and then, as we said, the immune system goes then to cause problems by targeting tissues that really are healthy tissues, and they're not supposed to be targeted by those white blood cells. So, long story short, it's a complex combination likely of multiple genes and an environmental trigger that most likely results in the development of vasculitis. There are some other things. Some medications may trigger vasculitis. There are what we call drug-induced vasculitis. There are some medications, sometimes antibiotics, sometimes medications used to treat other autoimmune diseases. For example, the TNF inhibitors that we use for rheumatoid arthritis and others. And there's data regarding smoking. In some studies, smoking seems to be a risk factor for the development of vasculitis, again, depending on the specific type of vasculitis. Of course, we know that smoking has a bad effect on blood vessels in general, and so anybody with vasculitis certainly should not be smoking because of the additional bad effects on the blood vessels. But smoking itself may be a trigger, at least in some individuals. So a few more questions that hopefully some of you at least will identify with is, why did it take so long to diagnose me with vasculitis? And why did I see so many doctors before and after the diagnosis? And part of the reason is because of this, because doctors are looking for a needle in the haystack, which, as you know, is often not easy to find. So vasculitis is rare, right? So in the context of a family medicine provider, an internal medicine provider, you're kind of your first go-to person when you initially have symptoms. That individual physician is going to encounter very, very, very few individuals with vasculitis during their career. And in medicine, even though we learn about these diseases in medical school, we really only learn about diseases when we're taking care of patients with a particular condition. That's what helps us recognize things. Now again, vasculitis is rare. So the most common form of systemic vasculitis is giant cell arteritis, or GCA. And this affects about 1 in 5,000 people over the age of 50, because people under 50 typically don't get this, per year. So this is the most common form of vasculitis, and as you can see, is already rare. But what about other diseases? Takayasu, 1 to 2 per million per year. Polyarteritis, 5 to 10 per million per year. GPA, MPA, maybe some variable numbers, but somewhere in the order of 10 to 15 per million per year. So you can imagine, even there aren't many physicians who take care of 1 million people, right? So even then, they're going to encounter very few individuals with these diseases, which is why then many of you have eventually made your way to more specialized centers. Of course, again, starting often with perhaps family physicians, internal medicine physicians, and then being referred to a rheumatologist, sometimes one or more rheumatologists, maybe even getting to more tertiary care centers, whether it's Mayo, Cleveland Clinic, and other large universities. So that's why it really is a journey. And vasculitis can affect any organ. So imagine how difficult it could be for physicians where one patient may come in with a sinusitis, or what seems to be a sinus infection, whereas somebody else comes in with a skin rash, and somebody else may come in with a stroke. So it's extremely variable. Some of the symptoms can be kind of vague, just like we've heard in the first presentation. Maybe it's, I'm not feeling well, or I'm achy, or I have some low-grade fever, I'm just not getting over this flu. So the symptoms are variable, they can be vague, and so they're difficult for the patient to realize maybe something odd is going on, difficult for the physician, right? A physician, a primary care physician may see 1,000 people with a sinus infection, but which one of those really has GPA? It's going to, again, difficult to find that needle in the haystack. So GPA and MPA. Some patients may have fatigue, not feeling well, fevers, but again, it can affect the eyes, the sinuses, perhaps the ears, the joints may become inflamed, the muscles may be achy, respiratory symptoms, shortness of breath. Sometimes it's hard to even understand that shortness of breath kind of creeps in gradually. Cough, coughing up blood in the urine, often very dramatic, but may not be noticeable because it may take us to do testing, either with a dipstick or in the clinic, to really realize that there is blood in the urine and there may be something affecting the kidneys. Neuropathy, so nerve damage, again, can be vague and difficult and subtle. because it often causes numbness, tingling, and perhaps pain, which is difficult to sort through. Is this neuropathy or something else? And of course, belly symptoms also sometimes can be vague. So in small vessel vasculitis, just some pictures here. As we said, folks may start with inflammation of the eyes. This is scleritis, where there's redness and pain in the eye. Some individuals, this is a chest scan, may have spots or nodules on the lung. These may not produce symptoms initially, but may cause shortness of breath, cough, coughing up blood, etc. If somebody comes in with a rash like this, especially in the hospital, of course, that's pretty traumatic. That's vasculitis that we can see, but again, oftentimes we need confirmation of that, and we often ask our dermatology, our skin colleagues, to perform a biopsy and really help us understand, is this really vasculitis, or could it be something else? When vasculitis affects the nerves, there may be a wrist drop, such as this individual who's not able to move their hand, or the leg, and a foot drop. Other forms of vasculitis, like GCA and Takayasu, can cause similar symptoms or symptoms that are different. So again, the not feeling well and so forth is common to many forms of vasculitis, but then GCA Takayasu may affect the blood vessels going to the head, leading to loss of vision. Again, joint pain, muscle pain, kind of a recurring theme. Some other vague symptoms sometimes that are difficult to appreciate: dizziness, weakness, headaches. Because these diseases can affect the arteries to the arms, folks with these diseases may have arm pain when they're using their arm, like maybe vacuuming or showering or washing their hair, and again may have other symptoms like belly pain. So the reason I put these two slides together is to show you that there are a lot of overlapping symptoms among different forms of vasculitis. So sometimes even as physicians or rheumatologists or specialists, even we have a difficult time separating out sometimes which specific type of vasculitis our individual patient has. Why do we need a team of doctors? Basically, it's because vasculitis can affect different organs. And we need these other individuals to help us, to help you. So we need the ophthalmologist to evaluate the eyes. I don't have the expertise or the tools to look in the back of the eye and to understand, is there vasculitis in the back of the eye? So that's where we need the eye doctor. The ENT doctors are able, with their tools and scopes, get a much more detailed look at an individual's nose, sinuses, perhaps ears, and so forth. The kidney doctor helps us with, of course, kidney problems. The lung doctor sometimes performing a bronchoscopy. That's where they can go in and get a direct look at the lungs, to look at the lining of the airways. A neurologist, if there is concern that the brain or the nerves are affected by vasculitis. A dermatologist. And then we often also enlist the help of vascular medicine or vascular surgery colleagues. These are individuals who, again, really focus on the blood vessels, not so much from the standpoint of treating the vasculitis, but sometimes people with vasculitis require either an angiogram or a surgical intervention, which is where these individuals help us. At Mayo Clinic, we have a collaborative vasculitis clinic where we actually work very, very closely, oftentimes in the same hallway, with our vascular medicine and our surgery colleagues. Some other questions. This is a common one, is what do my blood tests mean? As you know, you're going in for blood work on a very frequent basis. And why so many other tests? Well, first of all, probably the two most common blood tests that you'll hear your providers talking about are the SED rate and the CRP. And I'm sure you have these tests done at practically every visit that you're going in to your doctor. So the first thing is both of these are measuring inflammation. So remember, back to my first slide, is vasculitis causes inflammation, but now we can measure it because it's something we can measure in the blood, and it gives us an idea of how that inflammation is doing. Is it bad, meaning are those numbers high, or is it good? Have those numbers come down with treatment? So the SED rate is a very simple and very old test where they take a blood sample, they basically run the blood down a tube. Now the blood is kind of like a mixture of water and sand. Part of it is liquid called serum or plasma, and in that liquid there are many individual little red blood cells. So when you put the blood in a tube, just like the sand, the red blood cells are going to settle to the bottom of the tube. Once those red blood cells settle down after 1 hour, a technician in the lab, is going to measure the distance of how far those red blood cells fell. And that's called the sedimentation rate. It's how far the red blood cells have sedimented in that tube. That tells us how much inflammation there is. So the faster the red blood cells fall down in that tube, then the higher the inflammation. And you may see a range between 0 and 30. It's not a perfectly accurate test in the sense that it's going to depend a little bit on the lab that does the test, on the person that's reading it, and so the number is going to be a little variable. The CRP is more of a direct measure. It's a protein that's produced in the blood by the liver, and we can measure it in the lab. The one thing to watch for that we often see that creates some misunderstanding with our patients is that some labs do it differently or measure it differently. So in some labs, it's measured in a unit called milligrams per deciliter. And in some labs, like at Mayo, it's measured in milligrams per liter. So there is a tenfold difference between certain labs on how that's measured. So somebody with a CRP of 2 that's done in this lab is high, because in this lab, that would have measured as 20. So you just want to be aware when you're communicating these results. And again, part of the purpose of this conference, part of the purpose of the symposium is to empower the patients, keeping in mind that we may see many patients in a day or in a week, but you are the best advocate for your health and you are the most knowledgeable about your health. And if you're communicating these results to your providers and you're saying, hey, I just got a blood test, my CRP is 5 and I'm concerned, it would be very helpful to make sure that your provider knows which lab you're having it done at and what is their normal range. Because to me, somebody says my CRP is 5, I'm not going to know, is it normal or is it very high? And so just for you to be aware that there are some interesting aspects to these lab tests that we do. But the other test that you will probably hear a lot about is your ANCA. So ANCA stands for this long phrase, Antineutrophil cytoplasmic antibodies. What that means really is that your immune system is making antibodies. Antibodies are little proteins that normally help us fight infection. So normally these antibodies, they stick to bacteria or viruses or other things that shouldn't be in our body. But people with GPA, MPA, EGPA make antibodies that stick to white blood cells, and that makes the white blood cells angry and activated. So antineutrophil means that these antibodies stick to neutrophils. Neutrophil is another name for a type of white blood cell. They often stick to the cytoplasm. The cytoplasm is part of the white blood cell, which is not the central part, the nucleus. So each cell has a nucleus that contains the DNA, the genetic material, and then it contains a cytoplasm, this other area, which contains the proteins in the cell and the machinery for the cell to function. So patients with GPA, MPA, and EGPA make these antibodies in the blood that we can measure. And most patients with GPA, now there will be some exceptions to this, but most patients with GPA have a positive C-ANCA, is what the lab calls it, meaning that they make antibodies against this enzyme called PR3. So your physician may say your C-ANCA is positive, or he or she may say your PR3 antibody is elevated. That means the same thing. So the C-ANCA and the PR3, they're just two versions of the same test, basically. Now, what does that mean? So these tests are helpful with the diagnosis. So when we see individuals with these positive tests, they help us in making the diagnosis of GPA or MPA or EGPA. They're not always helpful. They can be helpful, but not always, in knowing how the disease is doing over time. In MPA and in EGPA, most patients have a positive P-ANCA and an antibody to an enzyme called myeloperoxidase. So again, your provider may say your MPO is positive or your P-ANCA is positive. They're basically talking about the same thing. But again, important to understand that these tests, this ANCA test, most providers are going to check them at every visit that you're going for your testing, but they're not as good as the SED rate and CRP at measuring how your disease is doing. So the SED rate and the CRP, they go up and down depending on the level of inflammation. The ANCA test, or the PR3 or the MPO, they may not track with inflammation. Sometimes they do, sometimes they don't. So why do we do all these other tests? We do a lot of tests because we have to check all the various organ systems, and we ask you a lot of questions. You're probably filling out lengthy questionnaires before the visit, but we need to know, do you have any symptoms related to your vision, related to your sinuses, to your lungs, to your kidneys, to your skin, to your nerves, to your gut? So we have to ask a lot of these questions, and we have to look or at least test for various organs. We need to know how your kidneys are doing. We need to know how your liver is doing, because a lot of medicines are going to be processed through the liver. So if somebody has a liver that's not healthy, that's important for us to know before we start treatment. We have to test for conditions like chronic hepatitis and tuberculosis. A couple of reasons. There are some forms of hepatitis that can trigger vasculitis, but then, as you know, with the medicines we're going to use for vasculitis, those may have bad effects, bad side effects in individuals who have hepatitis. They may have bad effects on people who have been exposed to tuberculosis, and so we need to know that ahead of time. But then we need to check the lungs. Yes, we can listen to the lungs, but we often need a chest x-ray, or even better, a CT scan, to see whether there are bad things going on in the lungs. So the lungs should be black. They should have air in them on a chest x-ray. This individual has a lot of fluffy white stuff, which actually turns out to be blood. Their lungs are filled with blood because they have ANCA vasculitis. And that's why we need very careful and detailed pictures of the lungs to help us understand, are the lungs affected or not. And as many of you know, when we come to vasculitis diagnosis, we almost always want to have a biopsy of a tissue that's been affected by the vasculitis to really be confident that the diagnosis is correct. Because as a physician, we are going to then be prescribing medicines that, as you all know, are not easy on the body, right? Whether it's long courses of prednisone, perhaps chemotherapy medicines, cyclophosphamide, other medicines, rituximab, biologics, methotrexate, etc. We want to feel confident that we're doing the right thing for you by being as certain as we can of the diagnosis. So we may ask for a skin doctor to help us with a skin biopsy, maybe the lung doctor for a lung biopsy, kidney doctor for a kidney biopsy. In some individuals, we're able to get a biopsy of the blood vessel itself. Like in giant cell arteritis, we can biopsy an artery here in the temple. So here's a picture of somebody who has vasculitis in their lung, and this is normal lung. So for example, in normal lung tissue here, the lungs should have these huge wide open spaces. The lungs are like a sponge. They need to have spaces in there for the air and the oxygen to come through, and for that oxygen to be absorbed by the body. So in normal lungs, there's a lot of space for air to be present, to be exchanged, for oxygen to come in, and for other gases to be expelled. In somebody who has vasculitis, these little purple dots again are all those white blood cells we talked about earlier, and they shouldn't be there. So again, they've invaded the lungs, they are causing damage, they're causing inflammation, they're calling in other cells to come in, and so now instead of a wide open space where we can breathe in oxygen, we now have this whole area of areas where there has been bleeding, where there are all these white blood cells, they've damaged the blood vessels, and then oxygen is not able to get across the lungs like it should here. And of course, this person is going to be having shortness of breath and other symptoms related to their vasculitis. In the context of large vessel vasculitis, oftentimes the diagnostic pathway is a little different. So in these individuals with, say, giant cell arteritis or Takayasu arteritis, again, most individuals will have high markers of inflammation, the high sedimentation rate, the high C-reactive protein. We may be able to get a direct biopsy of the blood vessel that we suspect is inflamed. And as we said, in giant cell arteritis, it's often a biopsy of the artery on the temple here, the temporal artery. But we also use a lot of scans and imaging studies with the help of our radiologists to be able to see. These arteries are large enough to be able to be seen on scans, such as CT scans or MRI scans, which is different from the small vessel vasculitis. So in small vessel vasculitis, we can see the consequences of the blood vessel damage, but we can't actually see the blood vessels, those tiny blood vessels. We cannot see them in detail like we can the larger arteries, as in individuals who may have GCA, Takayasu, or other forms of large vessel vasculitis. So CT scan, as you may all be aware, the patient here is laying on a bed and goes through a donut, which essentially takes oftentimes hundreds, if not a couple thousand, of slices of the inside of the body, and we're able to visualize not only the body's internal organs, whether it's the lungs, the kidneys, the gut, but also the blood vessels themselves, such as the aorta and its main branches. CT scan has some downsides because there is some radiation exposure, and of course individuals may be allergic to the dye that is injected to outline the blood vessels. MRI scans are also used to look at blood vessels, again, particularly the large blood vessels. MRI scan has the advantage that it is not related to radiation. It's really a magnetic kind of scan, but it does take longer. It's a smaller, more enclosed type of machine, very loud, very noisy, as you may know, and takes longer to scan. But again, these techniques are very helpful in helping us understand whether there is inflammation in the arteries and the blood vessels, and whether there is damage to the organs that are supplied by those blood vessels. Here are examples of individuals with vasculitis affecting the large blood vessels. So here is an aorta. This is again the main artery coming out of the heart. And this is one part of the aorta. This is the aorta coming out of the heart. And this is the aorta, again the same artery going back now in the back of the chest. But you'll see that these two are very different. And this part of the aorta is very, very thick. So this rind of gray tissue here is exactly what I showed you in the cartoon in my second slide, where those white blood cells have invaded the wall of the artery and are making the wall very, very thick, and so the inside of the blood vessel may be affected. The aorta here is more normal, and the wall is so thin you can barely even see it on the scan, but again, here we're able to see that thickening, that swelling, that inflammation affected by the vasculitis. Similarly, this is an MRI scan again showing inflammation in the wall of the aorta. Again, this is for individuals who have large vessel inflammation. These scans can help us look at narrowing in the arteries. Again, this is going to be more relevant for individuals who have large vessel or medium vessel vasculitis like GCA, Takayasu, polyarteritis nodosa. But in this individual, an artery to the brain, the carotid artery, went from being quite normal to now having an area of narrowing, which is of course going to compromise blood flow, and that is a consequence of vasculitis. It's a consequence of those white blood cells invading the artery, causing damage, swelling, and then narrowing of that blood vessel. Sometimes we use a fancier scan called a PET. A PET scan is somewhat of an expensive test, but in some individuals can be very helpful. And in this scan, this is performed by injecting a very small radioactive sugar. So it's glucose or sugar that has a dye with it that's radioactive. And then it allows us to see areas of the body that are inflamed. And in individuals with large vessel vasculitis especially, and some other forms of vasculitis, we can see that there is uptake of the dye. So the dye, if there's color here, this green dye, means that there is inflammation in the wall of the blood vessel. And this can be helpful for diagnosis or for telling us whether the vasculitis is getting better or getting worse. Again, this is only used in select individuals and in certain circumstances. In polyarteritis nodosa and in some other individuals, the radiologist, the X-ray specialist, may have to insert a catheter inside the blood vessels to give us an angiogram. So this is a kidney where we're now getting a dye outline of the blood vessels. And in polyarteritis nodosa, we see these little pockets of aneurysms, are called microaneurysms or small aneurysms, where the arteries have been damaged and they're leaking and have formed these small areas of widening that's causing damage to the blood vessels. So sometimes, even though this is used less commonly, sometimes we do need more advanced imaging with catheter-based angiography to evaluate the blood vessels. What about some other common questions? So moving on here towards the end, how is vasculitis treated? And of course, here I will be quite kind of more of an overview. And of course, the million-dollar question, is vasculitis curable? So as you all know, vasculitis is treated by suppressing the immune system. So we have to dampen the response of those white blood cells that are inappropriately attacking the blood vessels. But the treatment can be very variable, and the treatment is going to depend on how severe the disease is. And it depends on which organs are affected. So for example, the treatment of vasculitis that is causing inflammation in the lungs and hemorrhage in the lungs may be different from a vasculitis that is causing inflammation in the sinuses or in the joints. So we have to identify which parts of the body are affected by the vasculitis and then design a treatment plan in combination with the patient, and a treatment plan that is really tailored and customized to the individual and to the type of vasculitis. So of course we want to treat vasculitis to save life, because some forms of vasculitis can be very severe and even fatal if not treated. The most important thing, of course, is we want to prevent permanent damage to tissues and internal organs. There are some parts of the body that heal fairly well. For example, the skin, you can cut the skin, you can have vasculitis on the skin, but it generally heals fairly well. Some other organs, whether we're referring to the lungs, kidneys, the brain in particular, the nerves of the body, those are tissues that are more difficult to heal. And so again, it's extremely important that vasculitis is caught early and that the treatment is started right away. Of course, we want to improve quality of life. We want to get people back to doing things they enjoy. We want to get people back to work, etc. So how do we balance all this? So we have to balance the risks of the disease, and we have to balance the risks of the treatment. Because as you all know, there is no medicine that has no side effects. Of course, medicines have side effects. But we have to balance that against the effects of the disease. And the disease has bad effects. We talked about organ damage, affecting quality of life, maybe even affecting the duration of one's life. And so that's where we then have to take the acceptable risks of the medicines, and when we're suppressing the immune system, when we're dampening the immune system and those white blood cells, then we're not letting them do their job, and so there may be a higher risk of infection. You are all very aware of the side effects of prednisone, and we accept those side effects reluctantly, but we have to accept those side effects because we know that the consequences of the disease, the consequences of the disease without treatment, are going to be far worse than the potential side effects of the treatment. But it's a balancing act. So we talk about, when patients are newly diagnosed with vasculitis, you'll hear physicians and providers talk about inducing remission. And remission, as you heard earlier, has different definitions according to who you may ask. But basically what we're implying is that we want to put out the fire. So we want to turn off the inflammation that's causing damage to the body. And once we induce remission, then we want to keep the individual in remission. So it's no use treating the vasculitis for a week or 2 or 3, because we know that if we treat for too little, the vasculitis will be right back. So we want to treat appropriately. We want to shut the vasculitis off, and then we want to keep the vasculitis in remission. We want to keep that inflammation from coming back. Despite our best efforts and your best efforts, as you know, the vasculitis may flare. It may come back. The symptoms may come back, and we often may have to modify the treatment program then to start over and induce remission one more time. So in the context of GPA and MPA, when we talk about remission induction, we often use cyclophosphamide or rituximab in combination with high doses of prednisone. And as you are, I'm sure, very much aware, rituximab has oftentimes now taken more precedent or is being used more than cyclophosphamide. So most individuals with GPA and MPA will be treated with rituximab for remission induction along with steroids. There are other medicines that can be used for remission maintenance, such as methotrexate, azathioprine, or mycophenolate, or, again, ongoing use of rituximab for remission induction. And then if patients relapse, we often again use prednisone, and we use other medicines depending on the disease severity. When we're talking about GPA, prednisone has really been the main thing we've had, or almost the only thing we've had, for about 7 decades. Now there is an FDA-approved drug, tocilizumab, which can be used in some individuals to help reduce the reliance on prednisone. And this biologic, this tocilizumab drug, can be used to keep those individuals in remission. Again, relapses are not uncommon, and again, we often use prednisone and perhaps other medicines to help treat the disease. I know there are more sessions that are going to be very focused on treatment, and so I'll go over this just as a brief overview. In terms of Takayasu, again, similar medicines, often using a lot of prednisone, other medications that suppress the immune system, to shut off the inflammation, to keep the inflammation at bay, and then in individuals where we have relapsing disease, we might use other biologics, injectables, that can be effective in bringing the disease under control. So the bottom line is, the take-home point from these 3 slides is that we often use similar medications for different forms of vasculitis, but there are some differences in how we treat each individual disease, and that's why it's important for us and for you to really start with vasculitis, but then to narrow it down to the individual form of disease to understand what is the best treatment program. There are some things that all patients with vasculitis want to pay attention to, and you'll hear more about this, whether it's diet, exercise, trying to avoid infections because of the concern with these medications, so avoiding individuals who you know are sick, following appropriate hand hygiene, having a close communication with your providers to make sure that vaccinations are up to date, and to prevent certain unusual but potentially rare infections like pneumocystis, which is a rare form of pneumonia which can be quite serious. And then, of course, again, you'll hear more about protecting the bones and managing the side effects of prednisone. Vasculitis can result in flares, and flares can cause damage. And one of the ways to prevent damage, whether it's related to the vasculitis itself, so damage can occur due to the vasculitis itself, whether it's affecting the organs or sometimes from medications. And again, you'll be hearing more about the potential side effects and damage from prednisone. So the most important thing is that, number one, the fact that you're here means that you're very much aware of your disease and that you want to learn more, and I think that's an essential part of that collaboration with your provider. So early diagnosis, early treatment, close follow-up, of course, careful use of medications, and very close monitoring with laboratory studies, scans, and physician engagement. So education is essential. Great communication with your providers should be your goal. And ask questions, and we'll have time for questions in a few minutes. Again, the fact that you're here means that you're very vested in understanding more about your disease. Consider participation in research studies, which can be very variable. And we'll stop there, and I'm happy to take questions. Thank you.